The best part about watching my director scramble to explain herself to the hospital's board of trustees wasn't the job offer, though walking out of that meeting with a $310,000 director-level contract at Meridian Health System didn't exactly hurt. It wasn't even watching her try to justify why 6 of our highest revenue surgical units had quietly begun requesting transfers to outside consulting firms within the span of 8 weeks. The best part was knowing she'd caused every single bit of it the moment she stood up in front of 42 colleagues and hit that delete key like she was doing everyone a favor. My name is Victor Slade. I'm 51 years old, and 4 months ago I sat in a conference room on the 3rd floor of Eastbrook Regional Medical Center and watched everything I built over the previous 2 years get erased from a projector screen while the people I'd eaten lunch with for those same 2 years stared at their hands and said, "Nothing." I thought it was the end of my career. Turns out it was the starting gun. But I'm getting ahead of myself, because you need the full picture to understand just how completely my director managed to destroy herself with one keystroke. I came to Eastbrook as a senior clinical operations analyst about 2 years before all of this happened. I'd spent 26 years working in hospital systems. Started as an orderly at a regional trauma center in western Pennsylvania right after high school. Moved into supply chain coordination, then surgical scheduling, then department-level operations management. I'd run the OR logistics for a 400-bed facility in Columbus for 6 years. I knew what a hospital floor actually looked like at 5:45 on a Tuesday morning when a procedure got bumped and 3 surgical teams were standing in a hallway waiting for equipment that hadn't been sterilized yet because the case cart got mislabeled the night before. I knew it because I'd lived it, not because I'd read about it in a textbook. So when the posting came up at Eastbrook for a senior analyst role in their clinical operations improvement division, I thought, great, finally a place where I can put 26 years of that hard-won knowledge to actual use. Help some departments get more efficient, share some of what I'd learned. Maybe, just maybe, clock out before 7 for once in my life. What they didn't tell me in the interview was that the division was already bleeding credibility. 3 analysts had left in the previous 18 months. The departments they'd served were quietly routing their real operational problems around the COI office entirely, going directly to their own department heads or outside consultants rather than dealing with what they'd come to see as a paperwork exercise that generated reports nobody implemented. My new director, Lynette Marsh, had been running the division for 4 years. She had a master's in health administration from a well-regarded program. She dressed impeccably. She could quote every Joint Commission standard from memory, and she had absolutely no idea what actually happened on a hospital floor from the perspective of the people doing the work. She made that clear within my first week. I mentioned during a team meeting that I'd like to do a walkthrough of the cardiac surgical unit before we started an efficiency assessment, just to get eyes on how the prep flow actually worked in practice. She looked at me the way you look at someone who suggested something slightly embarrassing. "We conduct our assessments through structured data collection and staff surveys," she said. "Floor observation introduces too many variables and makes staff feel surveilled." I nodded. I'd been around long enough to know when to pick my battles. But I started watching the data they had, and what I found was exactly what I'd expected to find. Generic reports that could have applied to any hospital in the country. Recommendations straight out of process improvement frameworks that had never been adapted to Eastbrook's specific patient mix, physical layout, or staffing structure. Departments that had been flagged for the same inefficiencies 3 years running with no meaningful change, because the recommendations kept missing the actual root cause. The first department that gave me a real chance was orthopedic surgery. Their unit director, a straight-talking woman who'd been managing surgical services for 18 years, had been complaining for 3 years that their procedure turnover times were running 12 to 15 minutes over target, which in a high-volume orthopedic unit translates to serious downstream scheduling problems and very unhappy surgeons. Previous COI assessments had recommended better EMR documentation habits and revised pre-op checklists. Neither had moved the needle at all. I asked if I could spend some time on the floor. She said, "If you actually want to watch instead of just making a list, be my guest." I spent 4 days observing, not hovering, not clipboard in hand, just present and paying attention. I watched case card staging. I watched how instrument sets came back from sterile processing and where they waited before cases. I watched the handoff between the circulating nurse and the surgical tech during room turnover. And I found the problem, and it had nothing to do with documentation. Here's what was happening. Eastbrook Sterile Processing Department had been reorganized 18 months earlier to improve throughput. They'd done a good job. Their decontamination and sterilization cycles were actually faster than the national benchmark. But in reorganizing the workflow, they'd shifted the case card staging area to the opposite end of their facility from the OR elevator. What that meant in practice was that completed, sterilized instrument trays were ready on time. But the physical transport from sterile processing to the OR suite was taking an average of 11 minutes longer than the scheduling system assumed. The scheduling system had never been updated to reflect the new layout, so every single orthopedic case was being started with an 11-minute structural deficit built in, and nobody in administration had connected those two events because they'd happened in different departments, 18 months apart. The fix wasn't complicated. I worked with sterile processing and OR management to adjust the transport staging schedule. Carts going out 30 minutes earlier than the previous protocol, sequenced by case start time rather than by the order they came off the sterilizer. We also flagged a secondary issue. One of the two OR elevators had been reserved for patient transport and locked out of the sterile supply workflow, a policy that made sense in theory but created a bottleneck in practice during the morning rush. We worked with facilities and patient transport to create a coordinated schedule that kept the elevator accessible to both needs during the 4 highest volume hours of the day. Turnover times in orthopedics dropped by an average of 14 minutes within 6 weeks. That's fast. That's fast. And the orthopedic suite was running 8 to 10 cases on a peak day. The department picked up capacity for 2 additional cases per week without adding staff. At Eastbrook's average reimbursement rate for the procedures they were running, that's roughly $340,000 in additional annual revenue. The unit director sent me a handwritten note, which I still have somewhere. Lynette's response when I presented the results was to ask why I'd spent 41 hours on a project that had been allocated 22. The transport staging issue wasn't in scope, she said, highlighting something in her tracking spreadsheet. It was the source of the problem, I said. 22 hours wasn't enough time to find it. That's a resource allocation concern, not a justification, she replied, and moved on to the next agenda item. I should have understood then that we were not going to find common ground. The same pattern repeated with the cardiac ICU. Their charge nurse had been quietly furious for 2 years about what she called supply phantom, the phenomenon where the unit's inventory system showed adequate supplies on hand, but nurses were constantly running to central supply mid-shift because what they actually needed wasn't where the system said it was. It sounded minor until you understood that a nurse leaving a cardiac ICU patient to hunt for supplies wasn't a minor inconvenience. It was a patient safety issue dressed up in logistics clothing. I spent time on the unit during night shift, which nobody from COI had apparently ever done. The problem had 2 layers. First, the par-level replenishment system had been set based on average consumption data from 2 years ago, before the unit had taken on a heavier post-cardiac surgery census. Second, and this was the one that required actually being there to see, the replenishment happened during day shift, but the highest consumption period was evening shift, when post-surgical patients were most likely to need intervention. So supplies would be fully stocked at 2 p.m. and critically short by 10 p.m. on a busy night. The day shift nurses had no particular reason to notice because it wasn't their problem. The night shift nurses were compensating by hoarding supplies in their pockets and personal drawers, which skewed the consumption data further and made the system even less accurate. I worked with Central Supply, the unit pharmacist, and the night charge nurse to redesign the replenishment schedule and update par levels based on actual shift-by-shift consumption. I also helped them create a simple flagging system so that when any item dropped below a threshold mid-shift, it triggered a resupply rather than waiting for the next scheduled cycle. Total cost to implement, about $4,200 in process changes and a software configuration adjustment that the supply chain team handled internally. Nursing turnover on that unit dropped measurably over the following quarter. The nurse manager told me at one point that 2 nurses who had been actively looking for transfers had changed their minds. Nurse turnover at Eastbrook's level runs roughly $50,000 to $75,000 per incident when you factor in agency costs, onboarding, and productivity loss. 2 retained nurses was a real number in a real budget. Lynette's response was to note that I had exceeded my allocated hours by 31 and that my non-standard assessment methodology was creating inconsistency across the COI team's deliverables. The third situation was the one that really set the stage for everything that followed. Eastbrook had a problem with their emergency department boarding times. The length of time admitted patients spent in the ED waiting for an inpatient bed. Boarding is a nationwide problem for hospitals, but Eastbrook's numbers had been getting worse for 18 months, and nobody had been able to pin down exactly why, because the obvious metrics, inpatient occupancy, discharge processing times, were within normal range. Our COI team had issued 2 reports recommending an admit by noon initiative and improved bed request documentation. Neither had helped. I got pulled into this one because the ED medical director had specifically requested a fresh set of eyes after the second COI report failed to move anything. Lynette didn't love the implication, but she assigned me to it with a 20-hour budget and a clear note in the project file that I was not to exceed it without prior approval. I spent most of those 20 hours not in the ED, but talking to the people who existed at every transition point a patient crossed on the way from an ED bed to an inpatient room. The ED charge nurse, the bed coordinators, the transport team, the inpatient charge nurses on the 3 receiving floors, the environmental services supervisors whose teams clean the rooms. What I found was that the bottleneck wasn't any one of those groups. It was a communication gap between all of them that had been papered over by a system that looked functional on paper. When an ED patient was approved for admission, the bed coordinator assigned a room and notified the floor. The floor charge nurse then notified housekeeping that the room needed to be turned over. Housekeeping would dispatch a team, but the floor charge nurse's notification was happening through the same communication channel, a shared messaging system that also handled general floor communications, supply requests, physician pages, and half a dozen other message types. During peak hours, a bed turnover request could sit unread in that queue for 20 to 35 minutes before a housekeeper saw it and responded. Meanwhile, the transport team couldn't move the patient until the room was confirmed ready, and the ED was logging the boarding time from the moment of admission approval, not from the moment transport was dispatched. So the system was accurately recording a long boarding time caused by a communication delay that nobody had thought to measure because it fell in the invisible seam between 2 departments' tracking systems. The fix was a dedicated notification pathway. Bed assignments triggered an automatic direct alert to the housekeeping team's separate system, bypassing the general floor communication queue entirely. Transport got a preliminary estimated ready time so they could pre-stage. The floor charge nurse got a confirmation when the room was cleared rather than having to follow up manually. Average ED boarding times dropped 23 minutes within the first month. For a department that was boarding 40 to 60 patients on a busy day, that's a significant cumulative relief on clinical workflow. The ED medical director sent a note to hospital administration specifically mentioning the COI team's contribution. Lynette received the credit in the meeting where it was discussed, which I didn't particularly mind. What I minded was when she pulled me in afterward and told me that my creative workarounds were creating integration risks with the hospital's IT governance protocols and that she'd be documenting the deviation for my personnel file. I sat with that for a long time. I generated, by my own conservative estimates, somewhere north of $600,000 in documented and projected value across those 3 interventions: revenue recovery, staffing retention, and operational throughput. I'd done it by actually going to the places where the work happened and understanding what was wrong instead of analyzing data from a conference room, and Lynette was building a personnel file around it. Over the following months, the dynamic got worse in the way those things do when 2 people have fundamentally incompatible ideas about what success looks like. She'd assigned me projects with hour budgets calibrated to her standard assessment methodology. I'd use more time because the actual problems required it. She'd document the deviation. I deliver measurable results that showed up in department metrics. Rinse, repeat. I started keeping my own documentation, detailed records of every intervention, every hour spent, every outcome measured. Not because I thought I'd need it, just because it felt important to have a record of what was actually happening. The inflection point came at Eastbrook's annual Clinical Operations Summit in late January. The hospital's chief operating officer presented a department performance review that highlighted the previous year's improvements in surgical throughput, ICU supply reliability, and ED boarding times as evidence that the COI division's operational engagement model was yielding measurable results. He specifically called out clinical operational collaborational as a differentiating strength. I watched Lynette's expression during that section of the presentation. She looked like someone eating something that tasted wrong, but couldn't say so in public. After the summit, she scheduled a one-on-one with me and told me she wanted a complete audit of my project files for the previous 22 months. Every hour log, every assessment document, every communication thread. She framed it as a division-wide methodology review. I recognized it for what it was. I gave her everything she asked for, and I made sure it was thorough. 6 weeks of work went into compiling that audit. 81 pages covering every project I'd touched, every hour I'd logged, every outcome I documented, every deviation from her standard protocol explained in terms of what the deviation had found that the standard protocol would have missed. I was genuinely proud of it. It was the clearest possible record of what I'd been doing and why it worked, which is what made the morning of February 14th so surreal. Lynette had scheduled a division alignment session, all 42 members of the Clinical Operations Improvement Division, plus several department representatives who worked closely with our team. She told us in the calendar invite that we'd be reviewing current methodology and establishing unified standards for the coming year. I came in that morning thinking this might finally be the moment she engaged with the actual evidence and acknowledged that the detailed approach was producing results worth scaling. Instead, she opened my audit files on the main display and spent the first hour systematically using them as a template for what she was calling scope creep and non-standard practice. Every extended floor observation, every cross-departmental stakeholder conversation that exceeded her defined project scope, every hour I'd spent beyond her allocated budget, she walked through them one by one, in front of every colleague I'd worked with for almost 2 years, framing each one as an example of resource misallocation and a failure to operate within established protocols. I felt my face go hot somewhere around the 20-minute mark, and I kept it there through the rest of it by focusing on a crack in the wall above the projection screen. My coworkers mostly stared at their notebooks. A few glanced at me. Nobody said anything. Then she navigated to the root folder of my entire audit archive on the shared drive, the one I'd submitted to her at her request. And she said, with the kind of deliberate calm that means someone has thought about this moment, what this division needs to move forward is a clean baseline. Not a record of why our protocols weren't followed, but a commitment to following them. And she deleted the folder. All 81 pages. Gone. The conference room was the specific kind of quiet where you can hear the ventilation system. She was already pivoting to her next slide when my phone buzzed in my jacket pocket. I looked at the screen under the table. It was a text from a contact I'd met the previous year at a healthcare operations conference in Nashville. Someone who'd since moved into a leadership role at Meridian Health System, a large regional network that had been quietly expanding its clinical operations consulting capacity. The text said, "We've been watching what's happening at Eastbrook from the outside. Are you available to talk today?" I sat there for probably another 40 seconds while Lynette explained her new standardized assessment framework to 42 people who looked like they'd rather be anywhere else. Then I stood up, excused myself quietly, and walked out into the hallway. The conversation lasted 27 minutes. By the end of it, I had been offered the position of Director of Clinical Operations Innovation at Meridian Health System, covering a network of 9 facilities across 3 states at a total compensation of $310,000 annually, including performance incentives, just over twice what I was making at Eastbrook. The role came with a mandate to build and scale exactly the kind of detailed, site-specific operational engagement model that Lynette had spent 2 years trying to stamp out. I went back into the conference room. Lynette was mid-sentence, something about documentation standards. She noticed me come in and paused. "Everything okay?" she asked, in a tone that made clear she expected me to say yes and sit back down. I looked around the room. 42 people, most of them good at their jobs, working inside a system that was actively discouraging the kind of thinking that made them good at their jobs. "I owe the group an announcement," I said. "I'm resigning from Eastbrook, effective immediately. I'll be joining Meridian Health System as Director of Clinical Operations Innovation." The room did that thing rooms do when something unexpected happens, a collective stillness followed by the small sounds of people recalibrating. Someone's chair moved. I heard at least 2 quiet intakes of breath. Lynette's expression moved through several states in about 3 seconds. Surprise then, something calculating, then something that I can only describe as a sudden awareness of what she'd just deleted. "You can't resign in the middle of a division meeting," she said. "There are transition protocols, knowledge transfer requirements. My contract specifies immediate resignation is permissible in cases of documented hostile or retaliatory workplace conduct," I said. "Having my work publicly destroyed in front of colleagues at my supervisor's direction qualifies." The hospital's VP of Human Resources, who had been sitting in the back of the room as an observer, stood up and said she'd like to speak with both of us privately. I told her I appreciated that, but that Lynette had chosen a public setting for her actions, and I was comfortable letting the consequences follow the same format. I walked back to my office, packed what fit in a box, signed the offer letter on my phone, and was in my car by noon. I didn't reach out to a single department at Eastbrook. I updated my professional profile that evening and sent a brief note to my direct contacts in the hospital network to let them know about my new role. Within 72 hours, I had received messages from the unit director in orthopedics, the cardiac ICU charge nurse, and the ED medical director, all asking about Meridian's service capabilities and expressing interest in exploring what a transition might look like for their departments. I referred all of them to Meridian's business development team and stayed completely clear of any direct solicitation. But I also knew, and I think Lynette knew too somewhere in the back of her mind, that the relationships I'd built weren't stored in those 81 pages she'd deleted. They were stored in the fact that 3 departments had measurably better outcomes because of work I'd done alongside the people actually doing the work. You can delete a file. You can't delete 14 minutes off an OR turnover time that's been running faster for 6 months. Within 3 months, 2 of Eastbrook's highest revenue surgical departments had formally requested proposals from outside operational consulting firms. One of those firms was a Meridian-affiliated partner. I wasn't part of those conversations, but the professional network is not a large one, and information travels. I heard from a former colleague 6 months later. Eastbrook's COI division had been restructured. Lynette had not been retained in her leadership role. The hospital had engaged an external consulting group to assess why their clinical operations improvement initiatives had stalled. The external group's preliminary findings, according to my colleague, centered on a methodological gap between assessment recommendations and operational reality on the clinical floor, which is a polished way of saying that spending 22 hours on a problem and never leaving the conference room tends to produce reports that nobody can implement. I'm running clinical operations innovation for Meridian now. 9 facilities, a team of 14 analysts who I've been building specifically for their ability to do exactly what Lynette spent 4 years trying to prevent: go to the places where the work happens, understand the actual problems, and build solutions that work in the specific context where they have to work, not in the general context of a best practice framework. The thing I tell my team when we onboard new analysts is this: a hospital floor at 6 in the morning is a completely different place than a hospital floor on paper. The data will tell you there's a problem. The floor will tell you why. You have to go to the floor. Lynette thought she was deleting a liability. What she actually deleted was the last thing keeping her relevant to the people who were generating her division's results. And she did it in front of 42 witnesses, which meant that when the consequences arrived, and they always arrive, there was no version of events where she could claim it hadn't happened exactly the way everyone saw it happen. I don't spend a lot of time thinking about her, honestly. There's too much work to do, and it's genuinely good work. The kind where you end a day knowing something is measurably better than it was in the morning. But sometimes, when I'm walking a floor at one of our facilities and I watch a case cart move through a well-sequenced staging area, or I see a charge nurse glance at a supply alert and route it immediately rather than hunting for it at midnight, I think about that conference room in February. And I rig about the fact that she handed me everything I needed to leave and walked away from it thinking she'd won. Sometimes the most complete form of accountability isn't something you engineer. It's something you simply step back and allow to happen while you go build something worth building. I think about that February morning more than I probably should, not because it still stings. It doesn't, not anymore, but because of what it taught me about the way consequences actually work in the real world, which is nothing like the way we imagine them when we're in the middle of something that feels unfair. Lynette thought she was closing a chapter. She thought deleting those 81 pages meant deleting the argument I'd been making for 2 years. What she didn't understand, and what I don't think people like her ever fully understand, is that the work wasn't in the files. The work was in the OR at Eastbrook that was turning over 14 minutes faster. It was in the cardiac ICU where 2 nurses who'd been planning to quit had decided to stay. It was in an ED where 40 patients a day were spending less time in a hallway waiting for a room that was already clean. You can delete a folder. You cannot delete what has already happened in the physical world because of what you did. That's the part that took me a long time to really sit with. For most of those 2 years at Eastbrook, I was frustrated in the way that people get frustrated when they know they're right and they can't make the person with authority over them see it. I kept thinking that if I just documented it well enough, if I compiled the numbers clearly enough, if I made the case thoroughly enough, Lynette would eventually have to acknowledge what was in front of her. That's not how it worked. And honestly, looking back, I think that frustration was teaching me something I needed to learn, that doing the right work, with integrity, for the right reasons, is something you have to be willing to do, even when nobody in your immediate chain of command is going to recognize it. You do it because the patient in room 4 of the cardiac ICU deserves supplies that are actually there when the nurse needs them at midnight. That's the whole reason. The recognition is secondary. What got me through those 2 years wasn't certainty that it would work out. It was something quieter than that, a kind of stubbornness about doing the thing correctly, even when doing it correctly was being logged as a performance deficiency. I went to the floors. I talked to the people doing the actual work. I followed the problem wherever it led, even past the boundaries Lynette had drawn around what I was supposed to care about. That persistence, that refusal to do halfway work and call it good enough, was the only thing I actually controlled. And it turned out to be the only thing that mattered. I've thought a lot about what separates the Lynettes of the world from the people who build things worth building. It's not intelligence. She was genuinely smart, and she knew the frameworks and the standards better than almost anyone. What she lacked was the intellectual honesty to follow evidence past the point where it became inconvenient for her worldview. Real judgment means being willing to look at a result and let it change your thinking, even when your thinking is built into your job title and your performance metrics and the motivational framework you've constructed your professional identity around. She couldn't do that. Most people can't. The ones who can are the ones who end up building something. And there's a third thing, the one that's hardest to talk about without sounding like a poster in a break room. Character. Not in the abstract sense, but in the specific, daily, unremarkable sense of doing what you said you do for the people who are counting on you to do it, even when nobody is watching, even when the person above you in the org chart would prefer you didn't. The orthopedic unit director didn't send me that handwritten note because I filed a good report. She sent it because I showed up and I stayed until I understood what was actually wrong. That's the whole thing. That's the job. Lynette deleted 81 pages and thought she'd won something. What she'd actually done was remove the last obstacle between me and the place I was supposed to be. I don't hold it against her. I'm not sure I could have gotten here without her.